Good evening. My name is Brian Devitt. I'm Professor of Orthopaedics here at UPMC Sports Surgery Clinic, and I'm a knee surgeon. So the title of my talk this evening is Après Knee, Prevention and Management of Knee Injuries on the Ski Slopes. So now that many of you are going away to ski resorts, this is hopefully some salient information that should help you on your journey and try to avoid some ski injuries. So I'm just going to start off with a video. This video is a classic example of what happens on a ski slope. So you have friends who are laughing at you falling, but oftentimes the fall is an injury. So I just want you to hear what happens now as this skier comes down the slope. You hear that snap? Well, if you look at the person, that snap is not the skis coming off. That snap is the ACL rupturing. And you see that the individual is coming down a slope, probably at too high speed, and leaning back onto his skis, and that's what's causing the injury. And this is a classic example of how an ACL ruptures on a ski. So I was lucky enough, as part of my fellowship training, that I was away in Vail, Colorado, which is a ski resort, and one of the forefathers of treatment of ski injuries is this man here, Dr. Dick Steadman, and unfortunately he passed away just last year. But he described the ski as the ideal device to rupture an ACL. So really you have to be cautious when we're using skis, because there are a high rate of knee injuries associated with skiing. In terms of skiing, it's good for our business because people go away and injure themselves. It's a hugely popular sport. You see nowadays many people are heading away to slopes as holidays become a little more accessible, and it's a very enjoyable pursuit for the whole family. But it is a risky sport, and we see here just the idea of the type of knee injuries we get. So 35%, the majority of injuries occur in the knee, and that relates to what Dick Steadman said about the ski, because it's a high torque object that you twist at your knee because your boots are held in place. But you also get other injuries associated with skiing. The equipment has changed markedly over the 100 years or so people have been skiing. And what you see here, the old-fashioned skis where people had a much lesser binding and the boots weren't as high on the ankle as they are nowadays. You see the modern boot it goes up to the 2/3 the way up your shin, and your ankles are essentially fixed, that it just allows a bit of flexion and extension at the ankle, but very little rotation. So the rotation doesn't occur at the ski, the rotation tends to occur at the knee, and that's what happens in terms of getting ACL injuries. You'll often hear the people getting skis and then getting bindings, and the bindings are tightened up. So when you go to an instructor or a person who's giving you your skis, they will often talk about the din. And the din relates to how tight the boot is fixed to the ski. So when you are a very aggressive skier, you want your boots to be really tightly fixed to your ski. But when you're a more novice skier, you want your boots to be able to come away from your ski. So if you have any suspicion or suggestion of knee problem, you should probably get your din fit very low so your ski comes away from your boot and you don't turn your boot and your knee and cause an ACL injury. So the terrain and conditions are also very important. If you notice that the individual fell on very deep snow, but equally if you have icy snow or very slushy snow, they can grab your skis and be at higher risk of injury. And unpredictable behavior from people who are on holiday, probably drinking a bit too much, and or potentially just being a bit risky on holiday, they can cause collision, have injuries, which can often give rise to injuries themselves. So if we look at the example here, this is from Deer Park in Utah, where they give an example of how people have injuries, and they tend to be novice skiers where they're leaning backwards and they're not leaning down the mountain as we're instructed, and that creates the skier to be off balance. The hips tend to be below your knees. The uphill ski is unweighted, and then you tend to fall on the inside of the edge of the ski, and this causes the injuries. This causes your knee to be in a vulnerable position as the ski twists. As I said, the unpredictable behavior, it's great fun and the Après ski, but it's also when you're coming down the mountain with a few pints on board and you don't have that neuromuscular control you perhaps had in the morning, or perhaps even in the morning you're a bit hungover and you're going skiing, it does increase the risk of injury, unfortunately. And unfortunately, you just can't legislate for stupidity. So there's many things you can do, and this is an example of unpredictable behavior. So on the mountain, what can you do? First of all, primum non nocere is the phrase we have in medicine, to first cause no harm. So really you want to be make sure you're skiing within your area of expertise. So you don't want to go outside of your lane or ski in an area that you're perhaps going to get stuck in, but also go down a slope that you are not able to ski. You're much more likely to get injured, or more worse, even get lost or die or fall off a cliff. So that just goes with common sense, just to ski within your area of expertise. Also avoid hazardous conditions. So particularly if it's snowing or you're not a very good skier and you have very low light, it's very hard to see the undulations on the ground, and that can make you more likely to fall over. So even on a flat slope, it's really difficult. You have a whiteout. So beware of the hazardous conditions. And also be well able to stop before you start. So this is an example of another collision type injury, but someone a little bit out of control. So skiing is a hazardous sport. You need to stay away from people who are unpredictable, and get back into your comfort zone. So stay on the slopes if you're not so skilled to go off the slopes. So in the clinic, what do we do? Well, one of this article I often quote in my talks is by a very eminent Professor Après, and he talks about intelligent kneemanship, and doing appropriate examination is very important. But prior to that is taking a history. So typically an individual who injures their knee in history is skiing down a slope, has a fall, tends to hear a snap, as we heard in the opening video, but then has difficulty putting the ski back on and skiing down the mountain. So it's a more serious injury when someone is taken off the mountain by the ski patrol. But what typically happens is to go to the clinic at the end of the mountain, they get an x-ray and they get a very overpriced knee brace, and then they're sent on their way. But in terms of taking the history, you can really tell what's gone on from the fall, the crack that people tend to hear. That's very indicative. When you're doing a clinical examination, we look for a number of features, and you often compare to the normal knee because it gives you a good idea of what's going on. But we're looking for the presence of swelling within the knee, and swelling following an injury is typically blood. So it's bleeding because you've torn something, and very commonly it's your ACL. So that's really important to look at the other knee, and you see yourself when you take off your salopettes that one knee looks swollen. It's probably something you should get assessed. In terms of the clinical examination, we go through in a very systematic manner to assess all of the ligaments around your knee. So the ligaments on the side of your knee, so you can often injure the medial ligament or inside ligament. The ACL is very commonly injured, so you'll see a very swollen knee, as you see in this situation here. And oftentimes in the ski medical facilities, they're very limited. They're quite primitive. So what they typically do is simply an x-ray to outrule a fracture, and that's very important. But the clinical examination will determine whether you have a very severe knee injury, which may have more than one ligament injured, or whether it's a more routine knee injury with just a solitary ligament. And that has big implications. A lot of times they'll try to sell you a brace, and oftentimes the brace is not needed. But then they'll say, well, let's get an MRI scan, or let's have surgery early on occasion. And this used to happen occasionally in the US. And I would advise against this. I think that in the cold light of day, you can get further investigations when you come home and get appropriate treatment that's not under pressure or under the coercion by people trying to make money. So it's very important to consider that. The X-ray is example here can show you what a little flake of bone coming off from the side of the tibia. And that's an example of what we call a Sagan fracture, and that's indicative of an ACL injury. The MRIs can be done oftentimes in the ski mountains. They're poor quality, but in this situation, you can see some bruising at the mid portion of the tibia, and the femur, and also the back of the tibia. And this is indicative of an injury that causes an ACL rupture. You can do ultrasound scans, and these are cheap scans to get, and they often are effective for looking at ligament injury on the side of the knee. And then referral. So the referral is very important. So getting back to your home country is key, and being packaged and getting back safely. So that's very important. So as I said, in the cold light of day, this is when we really should see people, when we can just assess them appropriately. We take away the drama, we get them back where they're comfortable and the anxiety is lessened, they speak the language, and we can explain things and get the appropriate investigation. So early diagnosis is important. We need to know what we're dealing with, but oftentimes with knee injuries, we don't have to rush into surgery. And sometimes if you have decreased range of motion or your muscles aren't working properly, delayed management is much more appropriate. We then also discuss the treatment. Not all knee injuries require surgery, and I often tell people they should try to avoid surgery if they can, but certain situations will warrant surgery, and we'll go through all of the options with you in the co-light today. We remove the splints as soon as possible, and a lot of times these splints are unnecessary, particularly when they keep a knee straight. That joints are designed to move, and really we don't like keeping them straight unless it's a really serious fracture that has to be stabilized. For most ligament injuries, if the knee is not very unstable, you can move them, and that's really important. And being ready for surgery is dependent on range of motion, so that's really key, and that's the first thing we do. We also get people to weight bear as tolerated. That cartilage doesn't take a joke, and cartilage doesn't like not being loaded. So it's really important that we would get you back weight bearing as soon as possible, because if you're to have any knee surgery, we typically get you weight bearing very quickly afterwards. So it's very important that you're able to do this before surgery. So that's one of the things that people do. They get assessed, they get moving, and get back to their normal activities. So I'm just going to go through a few common scenarios, and these come into my clinic all the time, much more frequently at this time of year as people come back from ski holidays. So I'm going to start off with a novice snowboarder. So I'm just going to read out the type of referral I get. So thank you, Brian, for seeing Ben, a 14-year-old snowboarder who had an injury 1 week ago. He doesn't recall the mechanism, but there was swelling within 12 hours of his injury, and he was only able to toe touch weight bear. So just put his toe to the ground. He was unable to extend his knee. So you know that there's perhaps some fluid in the knee. An X-ray of plain film was unremarkable, except for some fluid within the knee. And an MRI was performed, which showed a small fracture to the inside of the knee and a sprain to the medial ligament. Also sprain to the ACL. He's currently in a brace, and I've advised him to non-weight bear. His mother will bring the films with her. So this is a very common condition we get. So in terms of the history, it was a contact injury turning, and he didn't feel a pop. He fell to the ground. He was unable to weight bear, and he was taken off the hill. No immediate swelling, but swelling within the first 12 hours. We know that something serious has happened. On clinical examination then, he held his knee in a flex position, so unable to activate the muscles at the front of the knee. He was walking with a limp. He did have normal alignment, which is important, and some swelling within the knee was what we diagnosed. And then he was unable to straighten his knee by 10 degrees, but had good flexion, and then had a 1 degree laxity or a slight sense of instability of his medial ligament, and he had a negative Lachman test. So that means that his ACL felt intact. So if we look at the x-rays here, we see that this is a juvenile because he still has growth plates, and there's no evidence of any fractures on these x-rays, so that's very reassuring. And then the MRI was performed, and this is what we see in MRI. We look for the presence of whiteness on MRI, so that indicates fluid on these sequences. So we see on the inside of the knee, the fluid is in this region of the medial ligament here on the inside of the knee. And we see that the ACL is this ribbon-like structure in the middle. And it does have a little bit of fluid in the knee, so we know that there's been some damage, but the ACL in this situation looks intact, which would be in keeping with the clinical examination findings. So this individual was just treated non-operatively and allowed to get on their way. So they escaped a major injury, which is very good. So that was a very common scenario we'd see. A lot of times we just give people reassurance, but we assess them thoroughly, do the proper investigations. So this is the second scenario, an experienced skier. So had a history of a high-speed fall turning on a steep slope, so akin to the first person we saw in the video. Heard a loud pop. Hopefully his friends weren't teasing him as he fell like the other individual. Tried to stand, but the knee buckled, had to be removed from the mountain by the ski patrol and had immediate swelling. On clinical examination, once again, when you have swelling, you typically are unable to straighten your knee. So people will see that a lot. Couldn't weight bear, couldn't stand on the leg, big effusion, and what we call ecchymosis, or that's bruising. We like using fancy words for bruising. So ecchymosis on the medial side, the inside of the knee, bruising on the inside of the knee. He then had a grade 3 laxity, so he had a huge amount of opening of the medial collateral ligament, and the test for the ACL was positive. So we would suspect this is a more multi-ligamentous injury based on the bruising, the swelling, and the laxity that we assessed at the time of clinic. So if you look at the x-rays here, so we didn't say which side, but I presume it's the right knee, but the x-rays show this area of a little bit of bone here. You see that on the x-ray. So that would indicate that this person has a has sustained an ACL injury, but possibly a higher grade injury than the aforementioned snowboarder. Okay, so they'll go on then to have a further investigations. So this is the MRI we see. So this is MRI looking at the side of the knee. We see lots of fluid within the knee. So this whiteness is blood. We also can see some bruising. So the color of bone normally on these scans is this dark gray or black color, and this area is a lighter gray here. So there's lots of fluid within the bone, or what we call bone bruising. And you can see the meniscus, which is this black structure, is hanging off at the back of the knee. So we know that this knee is far forward. So there's something has been ruptured in this case. And as we look into the middle of the knee, we see that the ribbon-like structure that we saw previously has been ruptured. So this is the ACL, which is torn. So thankfully, this person has got the appropriate imaging and be able to get the appropriate management, but there is a definite tear of the ACL here, as you can see. And then we look at the inside, the knee from the front, and we see that here where you'd like to see a nice black ligament, that's just this gray color. So we know that the medial collateral ligament has torn off as well. And that would be in keeping with the laxity or the feeling of looseness of that inside ligament. So that's a more serious condition, and that's a condition that would require ACL reconstruction and probably medial collateral ligament repair or reconstruction. That's a more operative case because it's a higher grade injury. So finally, we get a recreational skier. So a twisted knee removing the boot from the binding. So that's a very unfortunate type of scenario, but it's a common scenario, particularly when you're tired, where you're twisting your leg, you're frustrated, you're trying to get your boots out, which feel cumbersome. Felt a crunch in the knee. He skied on. He said it was fine after a whine, so maybe a little bit of self-medication there. It's no harm. Very painful that night. So this is very typical of an injury that happens during the day. You get more pain in the evening. Lasted the week through gritted teeth. So they probably drank a bit of wine, was able to ski on, and then in the cold light of day, they're uncomfortable, so they come to see us. So on examination, the alignment is normal, so they stand with straight legs. Some small evidence of any fluid and effusion is the word we use for that. Full range of motion, but pain at the end range. So when they're fully extending their knee or flexing their knee was painful. Pain on the inside of the knee, and then a normal ligamentous examination. So we're not suspicious of any ligament injury here, but might be suspicious of an injury to the soft tissue within the knee. And this is the side view we see of this person's knee. And what we're looking at is the meniscus. So the crunching sensation with twisting is very commonly a meniscal injury. So we see here is the meniscus, and it should be like a black triangle, but you see this white line going through the black triangle at the back. And so what they've done is they've torn the meniscus. And oftentimes people describe this as being fine at rest, but when they walk downstairs or twist or get in and out of a car, they find some pain. And I often tell people it's analogous to having a stone in your shoe. If the stone is sitting under your toes, it doesn't cause any problem. When it moves under the ball of your foot, that's when it really lifts you out of it. And that's similar to a meniscus. When that flap moves, that can often give an awful lot of pain. So we try to treat this non-operatively to begin with, but if the pain or symptoms are persisting beyond 3 months, or there's very obvious signs of displacement on MRI scan, then we would often have to do an arthroscopy and just remove that torn portion of the meniscus. Okay, so this is just another example of that, where you see the meniscus is just pushed out to the side there and there's some displacement. Okay, so that's it. So from my perspective, I hope you stay safe on the ski slopes and take some advice, and I'm sure Neil has given you some great advice to get fit before you get on the ski slopes. But go and enjoy yourself, be safe. But if you do run into any problems, we'll be here to see you and to treat you appropriately. Thank you very much.